So one of them is in, for example, a particular histology of melanoma called desmoplastic melanoma. This is a melanoma that carries certain mutations and is classified also by its appearance under the microscope. And for potentially many different reasons, this is a melanoma that recurs locally at a much higher rate. Could be as high as 15 to 25%. And so in those cases, we can consider doing radiation, particularly if a surgeon has some concerns about the margins, which can also be commonly at issue with this disease because they're usually pretty ill-defined and very spindly. Also, for the primary site, I've been called on to treat if a surgery is incomplete and if further surgery will lead to a suboptimal outcome. So sometimes there are, for example, large scalp melanomas where the surgeon really has done a large resection. There may have been a flap reconstruction, but then there's a positive microscopic margin for in situ disease, for example. And in some cases, when you always have to consider whether to do a re-resection, but if a further resection is not is going to be a major undertaking, then radiation can play a role in that setting. And then there are some areas of melanoma which are not easily resected. So mucosal melanoma, which is a rare entity, but it has come up from time to time.
Maybe we can define it for people, what does mucosal melanoma mean, basically?
So this would be a melanoma that arises from the mucous membranes, typically in the head and neck area. And this is an area, if it occurs in like the sinuses or deeper in the nasopharynx, structures deep within the head that are lined by mucosa but not easily resectable, then radiation also can play a role in the treatment at the primary site.
Yeah, I think one thing I also want to mention is one of the difficult thing about desmoplastic melanoma, the reason why it has such local high recurrence is that it has a tendency to sort of spread into the nerve, the neurotropic aspect of it. That's another name. But so obviously